Hi, my name is Todd Allen. I'm the Senior Executive Medical Director of the Healthcare Delivery Institute and help lead with our great team here the ATP program. Today, we want to spend some time speaking about service quality. If we go back to the core curriculum of ATP, we remember that Deming, under his core theory, said that all processes have three outcomes. One, the quality outcome. We've called that a medical outcome in the class. Two, a cost outcome. And medical outcomes and cost outcomes are tightly related through waste mechanisms. But three, there was a service outcome to all processes. And today we want to spend some time talking about that service outcome. Now, there's different ways to think about service. Sometimes we think about service as wait times or queuing. I want you to take that away for just a minute. That body of work and that outcome ties itself actually quite nicely to the PDSA cycle. What we're going to actually talk about today is from service is happiness, satisfaction, which operates by a different mechanism, and we want to walk through that science and that mechanism fairly carefully as we go along. It's not the same as dissatisfaction. We'll come back to that in a little bit more detail later. Dissatisfaction is quite precise. People know why they're upset with a service or a thing that you've provided. Happiness, however, satisfaction, again, slightly different mechanism that we want to dive into today, as we haven't had a chance to do that in the rest of the class. Now, four things we'll mainly cover today that I think are really important. Number one, how do patients respond to outcome rankings? Rankings, whether it's health grades or Leapfrog or U.S. News and World Report, are all around us. They're published on the web. They receive great publicity in the newspaper. How do patients respond to that? I want to go back in time a little bit and look at that science. Number two, conversely, how do providers respond to those rankings? And is there anything we can know as leaders of quality, as leaders of safety, anything that we can tap into to help drive improvement in our organizations given that particular science? From there, I want to link quickly, into a concept called shared decision making. Now, that's an important concept for you as quality leaders to understand. It'll be important for you to deliver on this thing called satisfaction. And finally, we'll look at what it means to be a customer or a patient in healthcare. And how do you, as a leader, understand the science of what it is to be a customer, and in particular, what it means to meet the expectations of customers? We want to understand, again, the science of how that works and link it back to the theory, the overall theory of process improvement according to the core concepts laid out by Deming. Now, to start with number one, let's think about how patients respond to rankings. Going back in the time machine a little bit, tell a quick story. David Chasson really introduced this concept in the literature as far back as about 1996 in the New England Journal of Medicine. In the years prior to that, he had served as Chief Quality Officer at Mount Sinai in New York. And in that role, he was asked by the Department of Health in New York to begin to build out a quality improvement initiative, essentially a project with respect to coronary artery bypass grafting, or CABG. He gathered all the right people. He built the team in a way that we have described in the course: physicians, nurses, data, pharmacy, anesthesiologist, all the people you'd need to understand and manage CABG appropriately. And they began to report on specific process and outcome measures relevant to that process. Well, as I mentioned, it was funded by the New York Department of Health, and one day a reporter got word that this thing was going on. He approached Dr. Chasson and said, "Hey, I understand you're doing this thing. I would like access to the data you've accrued over the years." Well, Chasson saw the danger there. This was a private group with private data who were really trying to improve the process, and he was worried that publication of the data, especially in a newspaper, would put the whole enterprise at risk, and so he said no. Well, the reporter recognized that Dr. Chasson was in an untenable position. As I mentioned, funded by the New York Department of Health, state money, and therefore under the auspices of the Sunshine Laws of New York. And he retorted then to Dr. Chasson, "Well, I think you're publicly funded. I probably get to see the data." Well, Mark again declined, knowing that his was a losing cause, but wanted to buy time to keep that important coalition together. Indeed, in the future, a court and a judge essentially said, Mark, you've got to make that data available to reporters. Well, Mark did a very thoughtful thing. He was given a date certain by which that data had to be released. And in the week prior, he essentially scheduled a conference. He invited to it reporters, lay people, community folks, hospital leaders, and said, hey, we want to talk to you about this initiative we've put together. More than that, we want to show you the outcomes we've achieved. And we're going to use the real data set from the project to sort of tell the story. And if you come, one, at the end of the day, you'll have the story. And two, we'll let you leave with, on that time, a CD of all the data that you can look through and report on your own. Now, in the background, Mark had done his best to calm the nerves of the people who served on that team, particularly the hospital administrators and the clinicians, so that they knew what was coming. They wouldn't be surprised, and he could hold the coalition together since they believed they were doing really good and important work. Well, that day came and went, and the data was released, and thereafter, every year on this date certain, Mark would release the data in the same way. About 6 years into it, he asked the question, hey, I wonder what this is doing. Is the public responding to this data and these news stories that would come out every time? The slide that you look at now shows that happen. Let me explain it a little bit. In the year column, it shows the year in which that data was relevant towards. So 1989 had clinical data, process and outcome related from 89. And in the column showing best hospitals and worst hospitals, that's the percentage of all cabbages that were done by a group of hospitals. Best hospitals, the top 5%, worst hospitals, the lowest 5% with respect to mortality. Risk adjusted, carefully risk adjusted. Mark Chasson has always been a careful scientist and did it the right way. Adjusted for age, gender, and comorbidity in the same way that we'd expect today. So top 5% hospitals, bottom 5% hospital. And as we relay it on the slide, those numbers in red texts show that the market share moved in the opposite direction that one would expect. In other words, if you were called out as a top performing hospital with 1989 data, in the following year, 1990, you should expect to have a higher market share of all the cabbages performed in the state. The red means it moved in the opposite direction, less market share. The green showed it moved in the direction one would expect. Conversely, with the worst hospitals, you'd expect that people would vote with their feet and walk away from those hospitals with respect to mortality. Again, almost a random mixture of congruent and discongruent behavior by patients. The first description really in the literature that showed patients, consumers, who had a chance to choose where to receive their cabbage surgery might not make decisions based on the data in a way that we might expect. First place. Well, at the same time, there was an effort by two senior statisticians from CMS, then it was called HCFA, Healthcare Financing Administration, Cliff Bailey and Henry Krakauer. They essentially were looking at a big data set and saying the same thing we've been saying in this class. Boy, we're spending a lot of money on healthcare, and our outcomes aren't what we'd expect. I wonder if there's a way that we could get this information to the public so, again, the public can choose to vote with their feet and go to hospitals that have higher cost or underperform in terms of quality. Now, it was the CMS data set, and so they had millions of records, easily enough to demonstrate statistical significance between hospitals. What they decided was to take 8 mortality-sensitive conditions, the usual suspects, right? Cabbage, pneumonia, hip replacement, knee replacement, gallbladder surgery, and essentially say, hospitals with 2 times the expected mortality rate would be publicly shamed in some report. They started in the congressional report, actually. They'd published these findings about hospitals, again, who had the mortality rate twice as high as one would expect. And then they would encourage local papers to essentially pick up and publish those stories. Hey, St. John's Hospital in Elsewhere, Nevada, was a high mortality outlier, and you should not go to that hospital when you need your gallbladder out. Well, they published that for a number of the years. And then finally, a researcher kind of said, hey, I wonder what the public is doing based on that information. So they went back and they looked, and they used a particularly interesting marker to determine whether or not it had an effect. Essentially, the idea was, if this hospital was publicly shamed, you would think that less people, again, would be willing to show up at their doors and be admitted, and therefore, in an item they could count, discharges would fall. Admissions would fall, and subsequent discharges would fall. What they found was really interesting and comported with what Dr. Chasson found and stated in his New England Journal article, that if they were called out as a high mortality outlier, discharges fell by less than 1 per week, a number so low that CEOs, CFOs could ignore it. Interestingly, as they went through this data and were counting discharges, they found occasions where discharges fell precipitously for a given hospital. And in almost all of those cases, they found it temporally linked, that plunge in discharges, admissions and discharges, temporally linked to a local story which described a single unexpected death or bad outcome. The modal event that they seemed to find was a complication of normal delivery, expected normal delivery, or a hemorrhage perhaps, or an unexpected infant or maternal death would happen, and it would hit the news. A name and a face in a public place, just as we've talked about, and that would cause people to say, oh my goodness, something must be amiss with that hospital. And again, discharges fell by about 9%. This is the second big step in the science of trying to understand this particular conundrum. You and I, we work every day to sort of measure particular process data points and outcome data points to help inform our decision making and particularly our improvement about process in the hospital. We think we react to, understand, and react to that data in a specific way. It might not be the same way that the public responds to these process level measures and these outcome level measures. And we've begun to accrue this data more and more that we've gone along. Now, I put up on the slide here a link to a health grade of a hospital, health grades report of a hospital in Utah, which is a great, great hospital. And you could pull up your own health grades information and take a look at it. And you'll probably, like me, scratch your head a little bit and say, I wonder how they came to that. And the literature, as it's come along through the years, seems to suggest that different methods of measurement, different methods of ranking, will consistently produce different rankings of hospitals, even within the same hospital, when you compare, let's say, leapfrog to health grades. It's a difficult science. And again, we've talked, if you think back to other parts of the course, we've talked about focusing on the frontline value-added work. And if we do that thoughtfully and well, one, we'll get the right process level measures, but two, they'll link up the chain to the right outcome level measures where we can be confident that we are changing those outcome measures truly. And you can manage towards some of those reports if you need to. Now, I want to fast forward a little bit and talk about the science of how the public, the framework of how the public may view these outcome particular rankings. And it's found in the literature of a terrific scientist by the name of Judy Hibbard. She and Margene Farber, two names you should know if you're interested in this literature, they tried to take a time out, a pause, and really assess, okay, if we put out data, statistical data for the public, what is the model by which they consume it? And they came up with this consumer choice model. Now, they did this through a literature review, a series of interviews, so a very thoughtful methodologic, and I think time-tested approach to this particular science. They said that in order to make a choice, a patient had to go through a few requisite steps. The first is that the patient or the public had to be aware of receiving comparative data. That is, when faced with a healthcare choice, they had to have in their memory bank, aha, I've seen some data relevant to Hospital A and Hospital B in this regard. I remember that. I remember some relevant ranking. Number two, they had to have some knowledge by which they could interpret that comparative information. It wasn't enough just to be aware, in other words. They had to have some knowledge by which they could say, this is better than that, and for this particular reason. Third, they found, and this is really interesting, it'll come to bear in the last bit of our chat today, they had to have a set of values. They called it an attitude. It's the collection of their value system, their life experiences, and their current needs that provided essentially a foundation upon which a decision might be made. Finally, what was requisite next, before they could actually make a decision, is they had to have the ability to change behavior. In other words, if you can't actually change anything, if you can't actually choose, then all of this stuff before doesn't really matter. And we've seen, and I want you to think about your own organizations and communities in this regard, we've seen that sometimes patients, by virtue of geography, by virtue of transportation, by virtue of housing, by virtue of a whole bunch of factors, don't actually have the ability to modify a choice. If I can't get in my car and drive to a hospital 30 miles away, if all I have is public transportation to get to a particular hospital or clinic, I essentially don't have the ability to modify a choice. So that behavior piece. So awareness of comparative information, knowledge about how to interpret that information, a value system in which the context of the decision can lay, and the ability to modify a choice. What they found in their research is the only thing that could be changed through experimentation was the awareness idea. That knowledge sort of came, and it was there, hard to really modify at the point of choice. Attitudes, a value system, certainly built into their life experiences and not modifiable, again, at the point of that choice. And behavior, the ability to modify it just, is what it is. So awareness is the one thing that could be changed. I think quite interesting. And as you think about your systems and how you engage patients and give patients a holistic experience on your healthcare services, please think of this model and understand that there is a science about how patients can progress through this. Now, fast forward up to the present time. If you're really interested in this, there is a Cochrane review on the subject that says there's low certainty evidence that the public release of performance data may lead to little or no difference in the services that patients choose to access. And you can read the rest of the quote by the slide on the slide. And in fact, I've even put the URL listing there for the Cochrane review. The science shows that the public doesn't interpret comparative data in the same way that we do, number one. Number two, that the comparative data, access to that comparative data, does very little, at least at this point, to be able to modify the choice. Patients, universally, if you ask them, will say, yes, we want that comparative data. Patients, if you ask them, will almost universally say, yes, we will use that data in making a choice about where to receive healthcare services. Again, patients, if you ask them, will almost universally say, retrospectively, we did use that data to help make a choice. It's only when you measure the actual choice that that whole scheme falls apart, and you really can't tell an effect when you carefully look. And yet I think we're going to get better at this. And in truth, this public data, comparative data, through any of the reports that we've mentioned is not going away. As quality leaders, you and I need to be thoughtful then about the process measure data we collect, the outcome level data we collect, and how those two things link across the spectrum of care to lead in to the necessity of public reporting. It's with us, I think, for our lifetime. And to be good quality stewards, we need to know about it and understand that science. On the other hand, remember, the second thing we want to talk about today is how providers, you and I, respond to the public release of performance data. Lots of accumulating evidence that shows we respond directly, if differently, from the public. This is a research paper, again, by Judy Hibbard, and it shows that when confronted with a public report about a thing, most hospitals, 88% of hospitals who were confronted by a public report about an untimely death or a serious safety event would respond with a quality improvement initiative. On the other hand, end of the spectrum, if a hospital was just, minding its own business and said, boy, we ought to launch a quality improvement initiative without the thorn or the thistle of a public report, only 9% of hospitals would do so under that guise. An internal report would cause 27% of hospitals to launch a quality improvement report. We respond as healthcare leaders directly to outcome rankings. The story in the paper, the report from CMS, at cms.gov, when we look at the rankings, we respond directly to improve in areas that are publicly called out. As leaders then, I want you to think about publicly reported data, not only as a way to inform the public, for whom it's ostensibly intended, but how to use it to inform your own colleagues, your own systems, the areas in which you have control, as another example of the imperative, as a catalyst to get things done. Because we respond, and it's the rule of rescue, right? We talked about that in earlier sessions. With a name and a face in a public place, we as adult humans have this built-in mechanism to try to do something better, to try to improve. And when we see these public reports, if you use them properly, thoughtfully, always with honesty and integrity, you'll find that they can serve as an additional catalyst beyond our professional values to get the good work done. So number one, the public doesn't respond in ways that we think. Number two, providers will respond in ways that we sometimes might anticipate, and we can leverage that to our good. In summary then, again, patients don't seem to change hospitals based on the public release of data. Now, if we hearken back to Dr. Chasson's project and initiative, a few other things were interesting. With the release of that CABG data, what they found was a quarter of the surgeons in that lower quartile, lower group, either moved hospitals or stopped doing the CABGs. Number one, that's interesting. Again, showing providers do respond to this data. Number two, mortality rates actually went down. Those hospitals that had mortality rates that were the lower rankings improved, as did those with mortality rates at the upper rankings. In fact, mortality for CABG in New York State decreased by almost 41%. Isn't that incredible? That when you followed the good structure of process improvement, you built a multidisciplinary team. You understood the process, in this case of ischemic heart disease and CABG, and the operative and postoperative components. And you leaned in and tackled the problem, you made progress, not only again on the process measures, but that outcome measure of postoperative mortality and CABG. Incredible. Now, other states saw the same improvement with similar initiatives. Not as much as in New York State initially, but still to a tremendous benefit. It's, again, another proof point of these very principles that we're trying to learn and master in our daily work. And finally, there's some data, as you're probably aware, that suggests that there's maybe a bit of cherry picking that went on. That's tough to sustain over time, and the data, I think, on that is a little bit less clear than we might hope. We talked about that principle as well, right? When confronted with an improvement initiative, Deming said you could do three things. One, you could actually work hard to improve that thing that you care about. Number two, you could game the system. Cherry picking might be a way to do that. Number three, you could outright cheat. Deming said those were the choices. Those are choices you and I are confronted with. Okay, well that covers the first two components of what we wanted to do today. I'm going to now slide into that area of shared decision making and leading to customer and expectation management. To do that, I'm going to tell a quick story. The story starts in 1987 with two market researchers by the name of Dan Willis and Brett Jacobson. They were hired by our first CEO, Scott Parker, and brought in, I think as one of Scott Parker's experiments. Hey, Dan and Brent, I'm going to give you about 3 years. Let's see what you can do with your talents, and then we'll see how it goes from there. The first sort of task they took on and wanted to be assigned to was an idea about return and recommend, the phenomena of return and recommend. What was it in a patient's experience, a family's experience, that would lead them not only to return to your hospital for services in the future, but to recommend your hospital or your clinic to others out there in the world with whom they came in contact. Now, they were professionally, well, I shouldn't say professionally, they had majored in marketing as both a bachelor's degree and a master's degree at a local university. And so they had experience in this methodology. And they took what they had learned academically and they brought it to this particular question. They did it the right way. They thought about the problem. They actually did a process map of the problem, what would lead to return and recommend. They began to build data sets that they would want to collect from patients about what was meaningful to them in this against this aim. And then they began to test and validate that sequentially. They actually brought the PDSA cycle, they actually brought the scientific method, which they teach in traditional marketing, to this problem. Their methodology was, in essence, unassailable. Now, the day came when they were asked to release that data, at least when they said they were ready to release that data to the executive leadership team. And so on the agenda that day, it was Dan Willis and Brent Jacobson present the results of the first return and recommend survey. It was a survey-based instrument. And there was a lot of interest amongst the executive leadership on those results. So everybody came, and Dan and Brent had a chance to stand before them and release those results. In total, there was 12 parameters, 85 questions within those 12 parameters that they reported on. A lot like what you see today from professional survey societies. In fact, you could make the case that this was pioneering work in healthcare with respect to return and recommend and patient satisfaction. Well, here was the list that they threw up on the board about the top factors that led to a patient or a family returning to the hospital and recommending. And it's a really interesting list from our perspective. Hospital cleanliness, smoothness of admission and discharge, the accuracy and clarity of the billing statements, the courtesy of the hospital employees, response times for calls and requests, level of technology that was available, nurse competency, availability of physician specialists, track record for medical complications. That wasn't borne by data, that was track record, what they'd heard in the community, availability of good emergency care, the price, and my favorite, the taste and the temperature of food. And this list was put up, and there was silence. It was met with silence, and it might be met with silence by you. Although we've come a long way, frankly, since 1986. There was some puzzled looks, some scratching of the head. Finally, one person spoke up and said, I don't get it. You've been working for over a year on this. You told us about your methodology, and this is the list you came up with. This isn't what we think makes a difference with respect to return and recommend. Where, they said, where are the medical outcomes? That lens by which we view the word, where are the medical outcomes? Dan and Brent were sort of puzzled by this and didn't quite understand. Now, again, given the perspective of the year 2020 versus 1987, we've come a long way. And you and I might look at this list differently today than we would have then. But then, before we started down this pathway of these decades of research, we were puzzled by the fact that patients didn't seem to track to medical outcomes with respect to this return and recommend phenomena. Now you can see surrogates in there as you look a little bit, but the direct medical outcomes didn't appear, and frankly, we didn't understand it. Well, across the country on the East Coast at Dartmouth, a group of researchers were also beginning to lean in and think about this particular problem. You remember when we talked about the quality utilization and efficiency studies done here at Intermountain Healthcare. One of the areas that we described was the area of benign prostatic hypertrophy, that chronic medical condition, and the treatments one might choose when you suffer from BPH. And we talked about some data in those early days that we collected in trying to manage benign prostatic hypertrophy. Well, medical teams at Dartmouth and the Dartmouth Institute were working on this same problem. Jack Wenberg, Elliot Fisher, Al Mully, and his team. They also saw this particular problem, and that given the choices that were available medically at the time, that patients seemed to be making choices towards watchful waiting, or TURP, transurethral resection of the prostate, or radical prostatectomy, in very varied ways. That is, they couldn't seem to see what factors were helping the patients make the particular decision. And they realized that the variation in decision making led to variation in outcomes and complications, and when that occurred, led to some very unsatisfied, very frustrated patients after the procedure. So they began to think about how do we talk to patients in ways, how do we get them information, statistics, in ways that would help them make more informed decisions that, and this was a very important realization at the time, decisions not only that were statistically sound, but were congruent with that value set that all patients came to the table with. You remember that part, that attitude section in Faber's consumer choice model? That's what they were getting at. When a choice matched up with values, good outcomes in terms of satisfaction were almost always achieved, even if a medical complication occurred. On the other hand, if a medical choice was in conflict with a patient's value set, almost no matter, even if the procedure was successful, there would be upset and anxious patients. So they began to work, and they actually started with these vignettes. They took professors, real professors at Dartmouth, who suffered from BPH and who made a choice about what procedure to undergo, and they began to film those with the old VHS Betamax sort of format. They began to film them telling their own stories and what led them to make their particular choices, with the hope that that would help other patients work through the process. What they found with careful attention was this, that patients wanted statistics, but it was hard for them in the way they've described, given that consumer choice model, to respond to statistics alone. And that statistics coupled with stories made a bigger difference. It still didn't work perfectly, and it was because of this last feature here, that stories matter. Stories that link statistics together matter. What they didn't realize at the time was there's lots of stories out there, and therefore they didn't ask the question, how do patients know which stories to believe? They know which stories to believe through the context of relationships. So stories trump statistics, but relationships trump stories. And that led to this idea of what's called shared decision making. Now, I want you to think about shared decision making as a small topic under the umbrella of patient activation and engagement. Okay? So we all want our patients to be more active in their health care, to be more active in their health care choices, to be more engaged in their health and their health care choices. We all want that. Shared decision making is a tool by which that broader effort, we think, can be achieved. It was pioneered by the folks at the Dartmouth Institute and at Dartmouth in the way that we just described, thinking about statistics, thinking about stories, and then how to build relationships with providers or with other patients or caregivers so that they could make choices that were congruent with their value set. Albert Moley, pictured here, was one of the leaders in that particular effort. And if you have a chance to Google him and his work and look at that, I've included a reference there as well. Fascinating science, and he's let out across the world, really, for many different systems. Worth a perusal if this is important to you. Here's the idea. Can variation in the choices that patients make, and therefore variations in the outcomes that are achieved, be lessened, be smoothed by making healthcare, and particularly healthcare decisions, more knowledge-based and patient-centered? And if patient preferences or patient values play a role in that outcome, in that process, how do we present to patients, right, those stories, those statistics, couched in relationships, whether it's with caregivers or with their families or the communities, right? Where to give them that communication? Where is it best placed? From whom should it be given? And how do we measure the accuracy of that information and the effect of that information? Big, important concepts. How do we do that? How do we engage in this thing called shared decision making to better match the choices patients make with the outcomes we hope to achieve and the values of those very patients themselves, right? So think about shared decision making. It will be important to many of you as a tool by which, again, the broader goal of patient activation engagement can be accomplished. It is, by definition, a collaborative process that includes sharing the relevant, evidence-based information, treatment options, outcomes that are likely to be achieved, matching it up with patient preferences, and having those preferences integrated into care plans. Now, decision aids are different. Decision aids are a sub-tool by which the goal of shared decision making can be accomplished. And I'd recommend that concept to you as well for your consideration. And think about what decision aids you might use in order to promote shared decision making in order to help patients be more activated and engaged. So I've shown here a compare and contrast of decision aids versus shared decision making. A common decision aid you'll see in the realm of stroke care, and think about them and recognize them as two different things, but as complementary. Okay? It can't just be decision aids by themselves. Decision aids, they're a part statistics and they're a part story. They have to be housed in relationships, in shared decision making in order to be effective. So many of you, as you engage in this work with patient satisfaction and patient engagement, will need shared decision making, which necessarily implies you're going to need decision aids. But recognize that the decision aids, again, represent the statistics and the stories, and shared decision making represents the relationships, and you'll work hard on that. Now, some of you may or may not know that Intermountain is working in this area, and we've done some careful trials, pilots, and tests of shared decision making tools. You can develop your own, but they exist out there in the world, and I have no interest, commercially I should say, in any of them. But if you Google shared decision making, it won't take you too long to find them. Recognize one thing. In our rollout, we encountered some real sticky points, and the adoption was not what we hoped. This is the short list of reasons that we found led to that challenge. And I'd encourage you to take a look at this list and design systems, design implementation strategies that overcome these particular barriers. Number one, training is important. We always rely on training. Training isn't the way, right, that we need to get quality improvement work done, but it's a part of the way. It's necessary, but not sufficient, in other words. Number two, think carefully about the patients for whom you design these particular tools. Think about how to adjust the workflow. This has been an important part, right, of process improvement theory, as we've talked about it. Redesigning standard work, redesign the workplace so that the process of administering shared decision-making tools and decision aid tools are standardized and routinized, right? Always transparent feedback. In our trials, clinics often felt unaware of the results that were being achieved, and the lack of that reinforcing feedback loop turned out to be an important barrier. And finally, we recognized that while underutilized with us, there was tremendous potential for positive impact on the care team and patient interactions. In other words, as you bring that team together and interact with the patient and the family, a real potential for synergy and positive reinforcement in that, which we underutilize as well. Now I'm going to jump to the Cochrane review again and just state that for shared decision making, the science is getting better almost by the month. If I would have presented this to you a year ago, 2 years ago, this review would not have been published, and the science would be less progressed. There's improving evidence that these shared decision-making tools actually are of benefit. And so I want to again include the reference for you and give you a chance to look back at the shared decision-making science to be better informed, therefore, about what you might use, how you might use it, and how you might train towards it. Okay, let's go back to Dan Willis and Brent Jacobson. You remember that there was some head scratching about that list of factors which would lead to return and recommend. Well, the other part of their report was they found that 94% of our customers, 94% of our patients were satisfied, would return and recommend the hospital. Now, no baseline to really go upon. It was a relatively new addition to healthcare measurement, but reportedly there was a lot of high fives, backslapping, and self-congratulatory behavior amongst the executives in that room. The tables turned here, essentially. Now it was time for Brent and Dan to be puzzled. As marketers, they knew that if a company, any company out there in the world, had a dissatisfaction rate of 6%, it was only a matter of time before they went out of business, before they became bankrupt. And so they were confused about how a group of executives in healthcare could assume that 94% satisfaction, or in other words, flip the tables, 6% defect rate could be acceptable. Well, if you tracked it back, most of it came from complaints about the billing system. Now, we had some real problems with the billing system back in the day. Again, track it back to 1987, and we've come a long way since then. But there was a lot of ways in which the billing system was offending folks. In fact, when carefully looked at, about 20%, 1/5, of our bills contained an error. Our hospital bills contained an error. Now, on our side, on the Intermountain side, we looked at the problem with a really interesting lens. About half of the problems in the bill were underbilling. We did something for the patient, to the patient, and they never got billed for it. About half the problems were overbilling. We billed them for something they actually didn't receive. Now, to us, it was kind of a wash. Imagine that perspective from Intermountain Health, kind of a wash. From the patient's perspective, however, especially for the overbilling phenomena, a real turnoff, a real dissatisfier. In addition, Intermountain Healthcare, as a nonprofit, was working hard to collect on unpaid bills. As a nonprofit, we do get credit for charitable care, but we don't get credit on the tax ledgers for unpaid bills, and therefore we were incentivized to go out and collect those unpaid bills. Sometimes it meant taking people to collection. Sometimes it meant taking people to small claims court. Again, a big dissatisfier. Now, I want to use that particular story and backdrop to teach one important quality principle that's known as the ripple effect. And here's the definition of the ripple effect. It was a core component of what Deming taught. And as a quality leader, I want you to have a clear definition and a clear story in your head of the ripple effect at work. The ripple effect, essentially defined, means that the primary effect of a service quality failure will almost always be overwhelmed by its secondary effects, okay? That is to say, the ripples of the service quality failure will almost always overwhelm that drop of the pebble that goes in the water in the first instance. I'll illustrate that a little bit. The billing system, again, was a big problem. Bills were incomprehensible, errors were relatively common, created a lot of redundant waste in the system. Well, in 1988, while this was going on, there is in the north of Utah a county called Cache County, made up of cities centered in and around Logan, and each of those cities has a mayor. At that time, there was a mayor by the name of John Stewart of River Heights, and he chaired a group called the Cache County Mayor's Committee or Commission. It was a rotating chair, and John Stewart happened to have the chairperson's role that year in 1988, which meant he set the agenda. Well, John Stewart was one of those patients of ours who received a bill for a service that he did not receive. And that put him on the defensive, to defend against the need to pay that bill for something that he didn't receive. And secondly, on the offensive, an opportunity to run some criticisms against Intermountain for almost a year. Well, here's a copy of the agenda taken from a local newspaper, archived local newspaper, for their spring meeting in 1988. And look at that. Look at this list. This is the entire agenda. Nothing about roads, nothing about police, nothing about, the barking dog in the middle of the night and how we ensure safety or security for the citizens of that county. All about a polemic against Intermountain Healthcare, urging the commission to deny tax-exempt status to Intermountain Healthcare, asking the hospital and Intermountain Healthcare to post and publish price schedules, to substantially reduce fees, to desist the practice of cost sharing, to treat its employees, especially nurses, better, and that we use our influence to reduce fees and treat patients in the public better. That was the entire agenda of the Cache County Mayor's Association. Again, based on, at least in part, of the bill that he received for a service that he did not, in fact, receive. Now, parallel story before we shift into customers. In 1988, there was a group in Utah called the Society of Non-Separatists. What their ultimate goal was to take away tax-exempt status from churches. Now, it turned out the Utah Constitution, the Constitution for the state of Utah, had potentially a small loophole by which a legislative or legal process could be navigated to reach that end. And the first step was through nonprofit hospitals. And as the biggest as the biggest nonprofit hospital system in Utah, the first domino that the Society of Non-Separatists wanted to tackle was to deny hospitals, and particularly Intermountain Healthcare, tax-exempt status, much like Jon Stewart's agenda. Well, the state didn't want that to happen any more than Intermountain Healthcare wanted that to happen. And so quickly a bill was passed in the legislature in that spring session and signed by the governor, which would send that bill, as we were going to modify the Utah State Constitution, for a vote of the general public in November, which had to be ratified by the public according to the Constitution itself. Well, that vote to amend the Constitution failed by less than 6,000 votes. And so Intermountain Healthcare, now not having the process of the constitutional amendment available to it, had to litigate along against, I guess, you should say, the Society of Non-Separatists. And it took about 10 years and $8 million to formally litigate that all the way through. A perfect example of the ripple effect. Remember, the secondary consequences of a primary service quality failure will almost always overwhelm the primary effects itself. That is to say, many years, millions of dollars, right, to reclaim this 6% percent of people who are dissatisfying year after year after year, who may have contributed to that vote to get to the outcome. The effects of that primary service quality failure in billing, vastly overwhelmed by the agenda, vastly overwhelmed by that lawsuit that proceeded over multiple years. Think about the ripple effect as you're designing service quality initiatives in your organization and in your area of influence. It's why we pay this so much attention, because the ripple effect is true. And if you fail today with the service quality failure, that ripple effect is going to overwhelm, again, the effects of that service quality failure itself. Be careful with this idea and design systems to think about service, to think about happiness, to engage patients, their families, and the communities and the work that you're doing, such that this phenomena can be avoided. Okay, now on to the last topic of the session. What I've put up here now is the formal definition of a customer that you would get in any marketing or business school education. A customer is anyone who has expectations regarding a process's operations or outputs. That is the technical definition, and it applies almost perfectly in healthcare. There's a little bit that's different in the terms of a patient and the vulnerability and the suffering that patients often have challenges and makes more complex this definition. But there are many places in healthcare where this applies perfectly. And so I want to focus in on that second word for a minute, expectations. Now, expectations come from meaningful and real places. They're not arbitrary rules, ideas, or whims that people have. The science of understanding expectations clearly shows that, one, expectations arise or are manufactured, come to be, from three primary sources. Number one, your past experiences, your own and others. Number two, what your current needs are. And number three, this value system pops up again, right? This value system, this set of unique internal preferences. Well, a quick story to illustrate this. In autumn of 2014, I was driving home from work downtown, and I began to merge onto a road that was a feeder road to the interstate, and so speeds picked up a little bit. It was autumn. I think I glanced to the right to look at some leaves, and I didn't see the cars ahead of me stop. I ran into the back of 3 cars, at least in terms of a chain reaction that day. Luckily, no one was injured. Long story short, I was in the market for a new car. That's, I guess, the punchline. Now, in entering that marketplace for a new car, I had expectations about how that process might go. I had past experiences with automobiles. The car I was driving at the time was a 4Runner, Toyota 4Runner that was pictured, and I loved that car for 2 reasons. Number one, it reminded me, as sentimentally, I suppose, of my grandfather. We used to get in his 4-wheel drive truck and have great experiences together, fishing, hiking, and camping. Number 2, when I moved back to Salt Lake City, I worked the evening shift in the emergency department at LDS Hospital, and I lived up a canyon that was nearby called Immigration Canyon. And occasionally during the winter, there'd be heavy storms in that canyon. Without my 4-wheel drive Toyota 4Runner, I'd never make it home after that shift ended at 3 a.m. or 4 a.m. And I loved getting home. It was quiet. I could sleep and recover there better than I could in a hospital. I've always been a light sleeper. So past experiences gave me a framework about what a good automobile was, what my expectations were for an automobile. But here in 2014, my needs were different. As opposed to when I bought that 4Runner, I now was married, had 4 kids, and a 4Runner wasn't the vehicle really of choice. My needs had changed even against my past experiences. Next I had a set of internal values about what a quality automobile might mean. I'm not an engineer. I'm not an automobile engineer. I don't know the technical specifications that equate to a good car. What I do know, again, is that there's a feeling, a value system with respect to safety, durability, reliability, sound manufacturing that I use when I approach and I look at an automobile and say, aha, that's a good one, or aha, that's not so good. So those 3 things came together as I entered that marketplace to say, aha, I've got an idea of what my expectations are with respect to purchasing an automobile. And I think you probably have things that track quite similar for you. Now, here's the good thing. We're going to take it up one level and say that we're in the business of providing a service, whatever that service might be, in whatever area of responsibility you might have. Here's the science around expectations, and it will be true of you in your purchases. It will be true of your patients and your customers, as it was true of me as I again re-entered the marketplace to buy an automobile. Expectations that someone brings to an experience cannot be mandated. They are what they are. No one could have mandated a different set of expectations for me on that day or the subsequent days about what a good automobile was. We've seen in society when governments or other groups try to mandate expectations, typically that experience ends quite badly. Number 2, expectations can be measured. Against my expectations of that automobile, you might measure that in a particular way. That's a good tool for you. Whether any of the survey instruments that you might use to assess patient satisfaction can be used. Just like Willis and Jacobson designed and validated theirs, they can be carefully measured. What you need to be aware of is measures of self-gratification. That is, framing the question, asking the question, presenting the question in ways that will push a patient into making a choice. That was a thing that they recognized at Dartmouth back in the day, right? Choices were one thing. Congruency with values were another. You can help patient make choices. You can subtly influence them. And medicine has done this quite effectively over the years. We've had some paternalism, let's be honest, right? We've influenced patients down a particular pathway that we prefer. So again, expectations can be measured, but be very careful of what's called measures of self-gratification, where you design the experience to produce the outcome that you want to. An easy trap to fall into. Number 3, expectations do change over time. My expectations there in 2014, I said clearly, different than if I would have needed a car 5 years or 10 years earlier. I'm going to show you how expectations change over time in a minute. And finally, expectations, the good news, can be modified through education. Okay, here's how expectations change over time. They move from, the science has shown, and this was done by Kano, a Japanese economist and scientist, well lauded for his work in this area, from what's called the supraconscious level to the conscious level to the subconscious level. The supraconscious level is essentially that proverbial delighter. Wow, I never knew that thing existed. I love that. That's great. This is where innovators live, and this is where we'd love you to live as an improvement scientist, right, with respect to service quality. Designing things, systems, programs to delight the customers that you achieve. Now, this is a great thing when you can do it, right? It really is a differentiator. I see it here, that's fantastic. I don't see it here, I'm going to choose to go that particular direction. Really great. It's a short space because the marketplace will do what the marketplace does. It will recognize that this thing exists, and other people will begin to scoop that up. Imagine when you first discovered, say, I don't know, remote-controlled televisions, if you're old enough to remember that, or a Blu-ray CD compared to a regular CD, or Wi-Fi enabled thermostats. Wow, terrific. I have got to have one of those. But now they're so commonplace, right, that you might not even notice them. That's the subconscious level. The conscious level is, as we described, I can see it there, I can't see it there, and it's the basis in which a consumer makes a direct decision. Pretty soon again, that's scooped up, and that thing becomes so common that you wouldn't even know that it wasn't there until that surprised you. It's like you walk into a restaurant today and you expect that food quality and safety is going to be there. You don't really notice it until it's gone and there's that outbreak of E. coli associated with something, right? You would be astounded. You would even think about remote control for a television until you went to some store, bought a television, came home, opened the box, and on that TV set was a dial which allowed you to change channel. You'd only notice it when it was absent. Now, this is the graphic that Kano used in his pioneering research. Now, the green line, again, is that supraconscious expectations. Quality improves, improves, improves along the x-axis until you cross a particular threshold, and then the customer response just shoots up. That's that innovative space. In the conscious expectations of the blue line, quality and the consumer response are directly, almost linear related. And then in the subconscious expectations, quality can erode, 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 erode until it reaches a threshold and becomes a revolter. You can choose, I think, as a quality improvement specialist to live where you'd like here. Some are innovators, as we described. You're looking for that thing that's a delighter. Others are opportunistic. They sit back, watch the marketplace, and have become very adept at sort of grabbing the best examples as they emerge. And it's a particular strategy that maybe you or an organization might want to engage in. Recognize, however, that this is the way expectations change, definitely change over time. Subconscious to conscious to supraconscious, and understand that particular science. It'll help you design your service principles in a way that's most effective for you. Finally, right, expectations can be managed through a good education. Now, here's the thing. You and I will have the opportunity in our lifetimes to buy a couple of automobiles. We'll have the opportunity to buy a couple of appliances, maybe a couple of homes, certainly, some television sets or computers. We'll become adept at that experience based on our past engagement with that activity. On the other hand, disease can be a bit of a rare event. And patients oftentimes don't have the experience of having their gallbladder taken out previously, of having a heart attack previously, of being confronted with diabetes previously. And all along that journey, the expectations will be different. You can manage those expectations no matter where you are with good education and with good patient engagement. Disease is a rare event. Patients know something is wrong, but they don't often know the diagnostic, the therapeutic, or the lifelong consequences of that particular event. And that's why they seek us out as trusted professionals. We have the opportunity, in other words, to help patients understand what to expect. To do this with grace and elegance and empathy will become the hallmark of the service that you render with the context of this particular science. Now, there's lots of ways to do that. I would commit to you, and I'd suggest to you that you make this a part of your daily thinking. If we hearken back to that list that Willis and Jacobson put out, it looks to me on the review now in 2020 that those patients that were surveyed, were essentially taking the technical for granted. They assumed that the medical outcomes would be what they hoped. What they were looking for were surrogates that represented quality according to their framework. Just like when I went to that automobile dealer, that I didn't know necessarily what constituted good, better, or best torque, what constitutes good, better, or best turning radius, what constitutes the best safety system. I had a sense of surrogates by which I made my own adjudication. How cleanly the door closed. As you drove down the road, the smoothness of the acceleration. As you turned, the sense of the stability of the car, right? Patients will take often the technical for granted. What they want to know is that, one, we understand them, and that two, as teammates on the healthcare side, we're communicating with one another. And as you think about the survey instruments that are out there, that's why communication plays such a prominent role. I put up there a copy of the book by Tom Lee, a terrific leader in healthcare, called An Epidemic of Empathy, how to make this part of our routine operations. And I want you to think about happiness, satisfaction, empathy, caring, and concern in lockstep with the curing that we're often engaged in. When we did additional context with patients, we asked them again in a little more detail what would lead to the phenomenon of return and recommend. These were the four big things that turned up. In the bold are the patient's words, the text that precedes it before the bold, how we framed it in our own particular context. Number one, attentiveness. That's the relationship idea. Did clinicians really spend the time to understand my concerns, my fears, my issues? Number two, was there trust? Did they believe the information that we had given them? Did we communicate clearly the disease, the nature of the disease, the diagnostic and therapeutic options, and the likely outcomes? Number three, we talked about it, shared decision making. That was control in the patient's own word. Did they have control over all the important choices? And was that control built on trust, the right information, as well built on a relationship, right? The stories, the statistics, and now a relationship. And when you had choices that could be made differently, say about how to respond to an early breast cancer diagnosis, how to respond to benign prostatic hypertrophy, how to respond to diabetes or prediabetes, did they have the chance to participate in that decision making and maintain control over their healthcare choices? We have to work with them very carefully to give them the right information and then help lay out the potential decisions, match them with their innate expectations and innate values in the way that we've talked about in order to achieve those best satisfaction outcomes. And finally, did we treat them with dignity and respect? Was there a sense of caring? I included at the link here a video which I think you'll find lovely, frankly. It's a trailer from a documentary about a clinician named William Alexander who died in 2016. His job at Loma Linda University was to teach caregivers compassion and empathy. And it's a lovely story to help remind you of the core principles and the values of medicine. So finally, if we can develop this particular chain, we'll be successful in this idea of satisfaction and happiness with our services. There's lots of little things we could do, and you could reach out to any number of sources to learn the fundamentals. Sit down, make eye contact, listen, use touch appropriately, be curious, interested, genuinely interested in the patients and their stories. That transfers, that becomes attentiveness, information transfer, shared decision making, dignity and respect. That will lead to the perception, not only the perception, but the reality of caring and concerned clinicians, which will lead to patients who return and recommend, who are delighted, whose expectations are exceeded, which will lead to business success. Here's that chain of effect for quality again that we've talked about so much, or the outcomes chain or the causal chain. The process level measures leading through a causal mechanism up to those higher level outcome measures at this point represented by patients who return and recommend and business success. In that vein, this list from Willis and Jacobson, again, represent the patient's values. They took the technical for granted. They assumed the technical was there. And these were the surrogates they were using to demonstrate shared decision making, to demonstrate trust, to demonstrate attentiveness, to demonstrate caring that meant satisfaction and happiness to them. So finally, I'll say this, that frontline, if we track it back to the caregivers, frontline caregivers' perception of quality as reflected in their morale, creativity, and local control absolutely will be, and you know this to be true by your own experiences and by what we read in the literature, absolutely will be transmitted to your patients. And therefore, with respect to service, right, quality therefore becomes the degree to which we meet or exceed the expectations. And our goal is to meet or exceed those expectations 100% of the time. I hope this quick review through the science of service quality and expectation management has been useful. Understand, just like with all process management and process improvement, service is one of those important 3 outcomes that Deming postulated. Service in, as we've called it here today, the science of expectation management. And we've given you a view into how you might think about it differently, understand it from its scientific roots, and therefore engage with it as an outcome just like the other outcomes that we're working on every day. We appreciate the time and attention to this. We'd invite you to reach out to us if you have questions. And as always, we look forward to our association in the months and the years to come. Thank you for your time and have a great day. Better has no limit.